We now come today from Egypt, the role of 3D lung analysis using CT in lung transplantation preparation.
Hello. We will talk about the role of 3D lung analysis using CT in living donor lung transplantation. This is a dream which became true in Egypt. The role of CT in preoperative preparation of a patient dedicated for lung transplantation is a matter of long journey, including the CT lung for both the recipient and the donors. This is including the use of advanced software for complete analysis of the whole lung structures. Regarding the role of CT, either for the donor or recipients for detection of any incidental findings that can postpone the transplantation or even change the decision for lung transplantation, assessment of the disease severity, and the most important, and this is our issue today, about the lung volumetry and the use of softwares applications for complete vascular and tracheobronchial tree analysis for the lung of the donor and recipients. Routine DCCT is important for donor and recipient to detect any subtle incidental findings that can abort the lung transplantation in the form of suspicious lung nodules, presence of non-diagnosed bronchogenic carcinoma, air trapping disease. Even we can assess the disease severity. Relative contraindications in the form of thoracic kyphoscoliosis, bony osteoporosis, vertebral collapse, and goiters to alarming the anesthesiologist about difficult tubal intubation. The 3D CT lung analysis and the advanced software is very important and the cornerstone in preparation patients of lung transplantation. The idea of living donor lung transplantation is to take the lower loops from two donors to replace the right and left lung in the recipients. And it's important to make a volumetry matching between the recipient and the donor lower loop. This is the whole right lung of the recipient, and this is the lower loop of the right lung of the donor. It must be, there is some sort of volume matching. We can accept up to 200% upper threshold volume mismatch, and minimum threshold up to 60 to 70% only. Why? Because too large donor lung will lead to pulmonary atelectasis and scarring of the donor lung, and small donor lung will lead to intractable pleural effusion and pneumothorax. Regarding the airway mapping, it's very important to do a complete analysis for the tracheobronchial tree of both the donor and recipients regarding the diameter and length, because the diameter mismatching or even matching between the donor and recipient will change the decision about the anastomosis type. If there is good matching between the diameter of the recipient and donor side regarding the tracheobronchial tree anastomosis, this will lead to end-to-end anastomosis. If there is some sort of mismatching, this will change the decision to be a telescopic anastomosis. Also, a lot of variants can be detected and can be a surgical problem regarding the surgery during resection of the donor lower loop, such as this example. There is a close or even an origin of P6 bronchus supplying the apical segment of the right lower loop is opposite the middle loop bronchus, and we must reserve the middle loop for the donor not to interfere with the function post-operatively, and this is considered one of the surgical dilemma, must be alarmed for the surgeon before the operation. Regarding the vascular mapping, this is a short demo video for the software already applied in our institute in Ain Shams University about the complete vascular analysis of the donor and recipients, complete arterial mapping for the whole vessels, about its origin, level of its origin, relation of its origin regarding the other loops, the relation with the venous, and we can detect every venous anomalies, which is very lot in pulmonary venous tree, and the relation with the tracheobronchial tree. This is almost, we can do a demo for the surgeon before the operation, the point of dissection, the vascular structure, where to dissect, how to reserve the other loops of the donor. This is an example of one of the contraindications to select a donor where the A6 branch supplying the apical segment of the left lower loop is proximal and high position regarding the lingular branch, and this patient have only one lingular branch. So if we make a dissection for the left lower loop, this will lose the lingular branch, and this will affect the function of the donor post-operatively, so this donor is aborted to be selected. This is also one of the venous anomalies that can abort the selection of donor, where the V6 supplying the or drainage the apical segment of the right lower loop has a separate drainage into the left atrium. So the complete analysis is very important as a preoperative preparation before lung transplantation, and even opens the door to be used in every thoracic surgery, because it dramatically will affect and will decrease the morbidity and mortality of the patients post-operatively. Thank you.
Thank you so much, Dr. Ahmed. Second talk for Dr. Mona Kamal, under the title Role of Cardiac MRI